welcome everyone this afternoon. For the clinical high risk for psychosis presentation, Danelle and I are going to co-present. So we're going to tag team. She's going to forward the slides. A little bit of background. Danelle and I have been working with the clinical high risk team in a nearby community mental health center for probably the last 4 or 5 years. It was initially started as part of a SAMHSA grant. And so we've become very interested in this. And some of what we're going to present today is from the literature and research, and then just some from our experiences with that team and other teams across the US. So next slide. So here are some of the objectives, just to give you a little sense of definitions of clinical high risk for psychosis, describing how this might, how we might differentiate this state from a first episode psychosis state, talk about some of the common comorbidities, and then talk a little bit about what providers can do to recognize CHIRP, or clinical high risk. So I may use CHIRP from time to time. So that's what the shorthand is for, clinical high risk for psychosis. Next slide. Just a teeny bit on the history of this. In the mid to late 90s, this idea of identifying individuals who were at clinical high risk, or ultra high risk, as they called it, in Australia, England, Europe in particular, they began to get the idea that could we identify individuals who were at risk to develop psychosis, identify some of the early signs of that, and could we provide an intervention, kind of prevention early on, with the hope that we could actually prevent psychosis onset, or at least delay it at that point, as to some of the bigger objectives related to that. Next slide. And yes, and as a result, we get better outcomes. So yeah, next slide. So in thinking about clinical high risk for psychosis, it's kind of non-specific, and it's often referred to in the literature as kind of a pre-psychosis phase. Sometimes the word prodromal is used. Usually there's some distress, and so some individuals seek help for it. But as I was saying, the non-specific signs are things like a person feeling off, like they're not able to put their thoughts together as clearly as before. Sometimes they begin to see shadows, feel more irritable, feel a bit more fearful. And then performance in different tasks, typically at school age. So performance in school seems to go down a bit. So kind of non-specific. Later on, if psychosis develops, it's like, oh, that's what that was about. But this is some of the early signs. And we'll go on to the next slide. This is a slide to kind of give you the full picture of schizophrenia, kind of longitudinally. So looking at the screen, the left side of the slide is that pre-morbid phase and prodromal phase. That would be where the CHIRP, or clinical high risk phase, is identified if we're looking at it kind of longitudinally. And then as it moves and progresses, sometimes it progresses to psychosis. And then from that first episode psychosis, there's varying degrees of recovery that can follow, including full recovery with psychosis. And many don't see that as happening, but we have data to kind of support the idea that recovery can happen when psychosis occurs. Next slide. So how do we differentiate between the clinical high risk states and a full episode of psychosis? There are kind of 2 main criteria that I think about. One has to do with just kind of severity and distress, but the other has a lot to do with how much insight or awareness the person has about what's happening to them. All right. And so we have a measure that we use called the Structured Interview of Psychotic Symptoms. It's called the SIPS in short. And they really have a nice structured way to kind of think about this. So if a person has an idea that their landlord, or maybe somebody at school, the principal, has something out to them, and they have this idea like, I think they've got something against me, but I'm not totally sure, that would be rated at a lower level, and that would be clinical high risk potential symptom, like mild. At the moderate level, it would be something more so along the lines like, you know what, I think there may be something going on, and they become much more fearful about it. And at that phase, they have more concern and conviction about it. And then at the further end of the scale, and this would be more in the psychosis range, where there's a very strong belief perhaps that the principal, landlord, whoever it might be, is trying to poison them, they're 100% convinced, or very strongly convinced, that would move more into the psychosis zone. So the level of insight and awareness and how much distress and interference it's causing is where we kind of draw the line, right? So if there's a lot of distress, interference, and there's less awareness of it being something like their mind playing tricks on them or something like that, would be the space where we kind of make the distinction between a clinical high risk state and a first episode psychosis. Next slide. The examples that are listed here of CHRP syndromes come from work with the SIPs that I mentioned, that one particular measure. In that particular way of thinking about clinical high risk, these are the syndromes, and we're going to go through each of these and kind of talk about them. I'm going to start with attenuated positive symptoms, and then Danelle's going to pick up from there. So the most common clinical high risk state or ultra high risk state is what they refer to as attenuated positive symptom psychosis risk. Easy to say, right? We call it APS. And this is when an individual expresses or demonstrates some of the core symptoms, positive symptoms like unusual thought content, suspiciousness, grandiosity, communication disturbance. Now, these symptoms or these experiences occur what we would call kind of subclinical or attenuated level. So they occur at least once a week, that last a month. They have to happen within the last year, and they do cause some distress. We need to see at least one of these. All right. So that's kind of the attenuated piece. We'll go on to the next slide. These individuals who show symptoms in this way account for about 85% of the clinical high risk cases. And this is also identified within the DSM as one of the categories. And another way to think about it is sort of sub-threshold of full psychosis, less severe, more transient, and the insight is relatively maintained, just as I was referring to before. And what the SIPS does is try to just provide some behavioral anchors and try to make it clearer what is somewhat of a, I don't want to say a vague concept, but they try to put markers in there. All right, so I'm going to high five and hand it over to Danelle to kind of pick up for the other syndromes here.
Tagged in. Thanks, Harry. So another one of the syndromes that, are considered, and it accounts for about 10% of the TERP cases. So not 85 like APS, but it's brief intermittent psychotic symptoms, or the BIPS. We love acronyms. And it's just as it sounds. So brief and intermittent. So there's been a recent, brief frank psychotic symptom. And so at least one of the 5 core symptoms has reached that level of psychotic intensity, but the individual is not disorganized. So they're still able to maintain that level of insight and organization. And then it, qualifies by, it does not last more than an hour a day for 4 days over a 1-month period. Several minutes per day, and in the last 3 months is when it had started. So, some of these we recognize are really difficult for an individual to be able to remember, to report accurately. And, this is a space where oftentimes having family members involved, or, that somebody from the family system who is also able to report, what they have observed or experienced with the individual to help identify how long symptoms are lasting, how frequently they're occurring, the level of intensity. And the last is the genetic and deterioration psychosis risk syndrome. So this is when an individual has a recent decline in their level of functioning, starting to have trouble at school or work or engaging with others. And also they are at genetic risk for schizophrenia spectrum disorder. So for example, psychosis risk is 1 to 3% with no relatives. When you have 2 parents who are 2 parents with psychosis, that puts you at a 45% risk, so considerably higher. 1 parent, 13%, and 1 sibling, 10% risk. So if somebody has a close relative that experiences symptoms of psychosis or schizophrenia spectrum disorder, in addition to some struggles with what's going on in their daily lives, they can meet criteria for this genetic risk. So, they could also have a first-degree relative with any psychotic illness, or the individual meets criteria for schizotypal personality disorder. That's another area where somebody could be engaged in services, continue to be monitored to prevent transition to first episode psychosis. So conversion rates to psychosis. So, it's really important for us to, learn how to predict transition to psychosis so that we can prevent a transition to psychosis, or at least have an impact on what that transition or initial first episode is going to look like. So we look for that presence of both subclinical symptoms and those risk factors like Harry was talking about. So current literature out there, and it's ever changing. These numbers are different from, 10, 15 years ago, but currently individuals who will transition to first episode psychosis at 1 year are about 15%. At 2 years, about 20%, and at 4 years, about 25 to 30%. So what that tells us is that many individuals who may meet clinical high risk for psychosis criteria actually don't go on to develop a first episode of psychosis, at least not at that 4-year marker. But for those individuals, those 30% that do transition in those first 4 years, that's where we really have this opportunity to have an impact. So, and especially from our work that we had done with the agency in Akron on a CHIRP program, I think that we experienced this as well. So comorbidities are very common with clinical high risk. That's oftentimes why people present to a clinic for support and services. So at baseline, in this one study, at baseline, more than 70% of individuals meeting CHIRP criteria had at least one diagnosable mental health disorder. Most commonly, we're seeing anxiety, depression, social phobia. And, commonly we'll see maybe 2 or 3 diagnoses or criteria that are being met. So somebody might be experiencing anxiety and depression around this time, and that's why they present for treatment or for services. And then it's unearthed that the individual might meet criteria for clinical high risk for psychosis. Here is just, a visual of that. So some of the other ones that, you'll commonly see are OCD. And also PTSD. So those are common comorbidities as well for individuals meeting clinical high risk criteria. So CHIRP, thinking about it as a challenge and an opportunity. So it is a challenge to prevent or delay the onset, but this is the space where we do have this really amazing opportunity to reduce the transition, or at least to moderate the experience for the individual who is transitioning to a first episode of psychosis. So what can we do as providers, or as part of a system and a treatment care team? So prevention is powerful, obviously. So individuals who access CHIRP services, as compared to those who do not access any kind of mental health services until they have a first episode of psychosis. So those who, are able to have the system intervene earlier on are less likely to need admission, psychiatric admission. They are spending fewer days in the hospital overall. They have a shorter time to get a diagnosis. So, oftentimes it's many years until somebody can get a proper diagnosis. So shorter time for diagnosis. They are not being admitted as frequently, and just an overall lower likelihood of admission. So I think that's really speaks volumes as to the opportunity we have in this space. And so, being aware, I think, is step one, that clinical high risk to psychosis is something that is, has been around for a long time, but in the States, it's just picking up traction and picking up some speed to do some more work around this. So, having this level of awareness, reaching out, to Best Center or others for more information, reading anything you can get your hands on. Screening is really a powerful tool. And there are tools. So Harry mentioned the SIPS, which is the full evaluation. But there are shorter screening tools that are readily available, such as the PRIME screen. And this can really help us to identify people that, we might have a sense that something's going on and they may need additional support or specialized support. And so we can get them to those services sooner and more quickly. As Harry mentioned, the gold standard currently is that SIPS. That it does require extensive training in the SIPS. You have to be certified. And so we do have pockets of people throughout the state who are certified in the SIPS, but the PRIME screen is readily available. The other thing that I think is very important, especially for this group, for integrated care teams, is really encouraging engagement in psychosocial interventions. So even if you are not necessarily a mental health provider, encouraging individuals to seek out these psychosocial interventions, keeping in the spirit of the biopsychosocial model, I think is really important, because we know that targeted psychosocial interventions can reduce that frequency of conversion to psychosis over time, or at least delay the onset and have improved outcomes. So again, the earlier psychosocial interventions, the better the outcomes. Also being aware that the basic principles of CHIRP care are typical standards of care across the board. So building rapport with the individual and their loved ones, family system, targeting what are the goals of that individual, and using your existing skill set. So even if you are not necessarily CHIRP trained, becoming more CHIRP informed and being able to adhere to the basic principles of any kind of, services that are available. And we know from international reviews that are pretty recent, I think it was 2020 or 2022, that therapy that is really titrated to the need, so individualized and specific to that person, proper assessment, offering supportive services like care management for that individual, and then really making sure to engage that family system, whomever that person identifies or is impacted by on a day-to-day basis. Critically important to engage them in these early stages of psychosis. So if you have any, obviously we'll do some Q&A now, but if you do have an interest in learning more or potentially bringing a program like this to your agency or to your organization, you can always contact us. So feel free to reach out to us anytime.